However, if you would like to hear about the cancer clinical trials in Atlantic Canada by Dr. Ravi Ramji Singh, I hope I pronounce his name, you have to move to the Concur session. I think Georgia has put the link in there, but I'm going to do that right now as well. So if you would like to switch rooms to select among this, where do I do? Yeah, okay. It's in the chat box now. So I'm going to stay. And Angela, are you here?
Hi, Santa, I'm here.
Hi, how are you doing today?
I'm good, thanks. How are you?
Very good. So do you have your slides?
I do indeed. Let me go ahead and share them.
Yes, please.
Okay. Let me know if you can see this.
Not yet.
Oh.
Stephen, are you on? Can you help Angela, please?
Yeah, we're here. You should
Hi,
presenter. Let's see. Do you have the share button down on your bottom? There we go. Oh, looks like you have multiple monitors. Do you?
I do. And it's
right.
not letting me minimize that.
If you want to stop sharing that one and share your other screen, we should have it. So we're getting your presenter view at the moment. So you should see the couple of different screen options. There you go.
Okay.
Perfect.
Perfect. All right. So can everyone see this and hear me okay?
Yes.
Perfect. All right. Well, I will get started. So that was a hard act to follow. So thank you very much, Derek, for sharing your story. I do think it's a good segue, though, because I am going to be talking a bit about cancer risk factors and cancer screening and the importance of early detection, which you really highlighted the importance of that very clearly. So you kind of stole my thunder and took away in the best kind of way, but really set the stage for the importance of what we're going to talk about now. So,
Angela, sorry if I may just interrupt you. I forgot to mention that this session is going to be recorded.
Okay, absolutely. Thank you. So I am Angela HYDE. I'm a medical oncologist here at the Cancer Center in Newfoundland. And I'm also an oncology lead for our translational genomics program. So hoping to bring more genomic studies both accessible for patients and increasing our research in that area in this province. So I'm going to move on if this is going to let me. Here we go. So some disclosures. I am a member of the token clinician on the Atlantic Cancer Consortium Patient Advisory Committee. My biggest disclosure is I'm actually not directly involved with any of our provincial cancer screening programs. So I did have to rely on some of my colleagues to share some information that I could pass on to you all today. I don't have any other relevant disclosures. So my objectives really were to kind of look at the importance of and the goals of cancer screening. I'm taking more of a population risk approach, looking more at what screening is available for those who don't have a family history, who are not at the higher risk, but just the population level screening, specifically for colon, cervical, lung, and breast cancers. I do touch a little bit on some of the higher risk screening available for breast and colon cancers, as well as a successful prevention program here, which is our smoking cessation program. All right, so getting into it. So in Canada, I mean, we all know that cancer is a huge burden on our society and on our individuals. The Canadian Cancer Statistics has a great website, cancerstats.ca, where you can really play with and look at this data. So I was able to generate these figures that show us, you know, you'd expect about 120,000 women and 127,000 men will be diagnosed with cancer in Newfoundland just in 2024. This circle here illustrates the different types of cancer that make up those that are diagnosed in women. And you can see this pink here represents breast cancer, so approximately a quarter of all diagnoses, followed by lung cancer and followed by colorectal cancer. So together, those three make up about half of all cancers that we see in women. In individuals diagnosed or assigned male at birth. We see prostate cancer represents almost a quarter of diagnoses, lung cancer, the second most common, colorectal, and then bladder. And so together these four make up again about half. So it works out that just under half, so 1 in 2.2 Canadians are expected to be diagnosed with cancer in their lifetime. And about 1 in 4, 1 in 5 will die from their cancer. And you can see that the representation of the cancers that lead to the most deaths actually shift in terms of colors, even though breast cancer was the most common diagnosis. Lung cancer is the most common cause of death in women and in men. So I'm going to move on. This I thought was a kind of played with and saw just where this is an Atlantic meeting. I broke it down. So this is Nova Scotia, New Brunswick, Newfoundland, and PEI in terms of number of new cancer cases. And you can see there are more in Nova Scotia representing the higher population there. And the different colors represent the different cancers that make up the diagnosis. So you can see that for every province except for Newfoundland, the most common is cancer diagnosis is this yellow, which is lung cancer. For Newfoundland, the most common cancer diagnosis is actually colorectal cancer, so colon and rectal cancers. So there are some differences between populations, even in Eastern Canada. And, you know, you can actually play with the data further and bring it up to show the specific cancers, the number of new cancer diagnosis for each type that you'd expect to see in each province. And the ones that are circled here are the ones that we actually have screening programs for. And that's what I'm going to talk about next is cancer screening. So as Sevtap described for you, gave this definition just part of our last session. A screening test is a test that's performed on an asymptomatic individual who is considered at average risk. Oh, sorry, someone's asking for the Nova Scotia, since we're in New Brunswick. Those were there as well. That's the second column there was the New Brunswick data. Okay. And again, all of this is available on cancerstats.ca. That's a dashboard and you can play with that. So it is all there. Sorry if I didn't highlight it. Okay. So just reading the chat as I'm presenting here. So the purpose of the screening, like I say, it's a test on asymptomatic individuals at average risk that will allow for early detection, early treatment, and early management of disease for better outcomes. That's the goal. And so a key point, though, is screening does not equal diagnosis. We do not diagnose a breast cancer on mammogram, but we identify a region of concern that requires further investigations to lead to a diagnosis. So if somebody has symptoms or they're at higher risk, you wouldn't be doing the screening, you jump straight to the diagnostic test. So that's why the screening for population-based really is for asymptomatic individuals at average risk. Okay. So the goals, like I said, is to, really to reduce the disease-specific incidence, so to prevent disease. Also to confirm the absence of disease in individuals and populations. If it is there, to detect it early. That's going to improve outcomes for the patients, but also for the healthcare system. It can lower healthcare costs if diseases are prevented or caught earlier when they're more manageable. And of course, if you're preventing disease and finding it earlier, you're also preventing death from disease. So these are the big goals of any screening program. So criteria for a screening test, as Sevtap also mentioned, we don't have screening tests for every cancer. And why is that? So for a screening test to be valuable, there has to be a significant burden of disease in the population. You're looking for something that affects the population significantly. There has to be a preclinical stage, so a stage of the disease before we have any symptoms, before we know it's there, but that we can somehow use a test to detect that it is there, or that there's a pre-cancerous lesion or an early stage that we can detect. It has to be a situation where early detection actually improves outcome, and that the early detection, that the test has acceptable morbidity, meaning it's not too invasive, not too painful, something that we can accept as a test. We're not going to be looking at, everyone's not going to be going along with, a surgery to look in and examine, looking for cancers. That would be not acceptable, but an imaging test would be much more acceptable. So something acceptable, inexpensive, relatively accurate, not too invasive, and for which there is a treatment available once the disease is detected. So these are the things that we need for our screening tests. So of course, there are many cancers for which such tests do not exist, and so for which we do not have screening programs. And there are some cancers that have screening tests, but they're more invasive, they're higher risk, and they're more costly. And so, it doesn't make sense to offer them at the population level. And so we've reserved those screening tests for people who are at highest risk. So not for population screening, but for specific, more high-risk screening. Okay. We have to keep in mind when we're screening that there are potential harms, false positives, false negatives. So false positives would be a test that signals that there could be something there that leads to anxiety, leads to additional tests and investigations, including biopsies and other invasive procedures when there is no cancer there. A false negative is just as worrying, if not more, because that gives us a false reassurance that there is no disease when in fact there is. So these are things that are potential harms from screening, as well as incidental findings, finding things you weren't looking for that you then have to manage, and the potential to overdiagnose. So cancer screening in Canada is not as unified and cohesive as we would like. So for a number of decades now, we've had the Canadian Task Force on Preventative Healthcare. Part of their mandate was to develop national guidelines for screening. We have also at the same time had the situation that healthcare is delivered in a provincial or territorial manner. So every province really is responsible for their own healthcare. And so there are different provincial and regional healthcare and screening guidelines. And they're also association and society guidelines. For example, the Canadian Gastrointestinal Society will have guidelines for when or how often to do colonoscopy and other screening tests. So we have different recommendations for the country, for different provinces, from different specialty organizations and societies, and there really is not a cohesive national approach to screening. To further complicate this, just a couple of weeks ago, hot off the press, the Federal Minister of Health actually paused the work of this Canadian Task Force on Preventive Healthcare, as recommended by an external review, as many of the guidelines are more than a decade old, and the approach used in developing a lot of these guidelines is quite antiquated and really needs to be updated, and kind of the work needs to be modernized. So again, we're looking at the provincial healthcare guidelines as well as society guidelines, and every province has a different approach to screening. So starting at colon cancer screening for the specific programs, again, recall it's the third most common cancer overall in terms of new diagnosis, the 7th most common cause of death from cancer, responsible for approximately 11% of all cancer deaths. And Newfoundland actually has the highest colon cancer incidence and the highest mortality rates from colon cancer in Canada, and honestly quite high for the world. Risk factors, increasing age is one of the biggest risk factors, family history and genetics, as we've heard. So approximately 2/3 to 3/4 of colorectal cancer cases are considered sporadic. So the remaining 1/4 to 1/3 have either a familial risk or hereditary risk. And the difference is we see clustering within families, and that is not always related to an inherited cancer syndrome or a specific gene variant that's inherited within the family. Really, that only applies to about 2 to 5% of colon cancers. But we do see in 1/4 to 1/3 of colon cancers that there is an increase in colon cancer in a family. And whether that's from sort of less penetrant other genes that are involved, shared environment, shared risk factors. So together it makes up about that we see familial or hereditary cancer in 1/3, 1/4 to 1/3. Other things that increase risk of colon cancer would be things that lead to inflammation in the bowel. So inflammatory bowel disease like ulcerative colitis and Crohn's disease, diabetes and obesity both have increased inflammation and therefore increased risk of colon and rectal cancers. And there's a number of lifestyle factors in diet that can also increase our risk. So the goals of colon cancer screening is actually to identify early precancerous lesions, these polyps, and to remove them to prevent cancer. So screening tools are generally now stool-based tools, tests that you can do at home that test for tiny amounts of blood in the stool that you can't even see. And if that's found to be present, you then offer the gold standard, the diagnostic tool, which is colonoscopy, which has the distinction of not only being a diagnostic tool, but also a therapeutic tool, because not only can you identify these polyps, you can remove them and therefore prevent cancer. Now, all to say, so these little polyps, as you can see in this picture here from an endoscopy, they're these little growths that are within the lumen or within the tube of the colon. And as stool, feces kind of goes past. They can bleed a little bit. You don't notice it in your stool, but this is what the stool tests are picking up, is that little bit of blood. Not all polyps will become cancerous with time. In fact, most would not. And if they do, it takes a long time. So the ones we worry about are the ones that have grown greater than 1 centimeter in size. But even if those are left untreated, they're left there, only about 2.5% will become cancerous in 5 years. And if you're looking at 20 years down the road, still less than 1/4 of them will become cancer. But of course, because that risk is still there, if we identify them, remove them, we're actually preventing cancer, which is the goal. So since June of 2023, all Canadian provinces and territories use a FIT test as the screening test. It's a stool test called fecal immunochemical test, or FIT. A sample, a toolkit gets sent to the home that has these little strips. You apply a little bit of stool, put it in the biohazard bag, and you mail it in. And they assess that in the lab then for small amounts of blood. Some of the earlier screening guidelines have talked about FOBT, or fecal occult blood testing. It's a different test and not as good as FIT, so we're generally not using that anymore. Other recommendations have talked about flexible sigmoidoscopy, and I like how that's been likened to breast cancer screening of only one breast. If you look at the diagrams here, B is what a flexible sigmoidoscopy would do. It would only be able to examine really that left side of the colon, and you're really not examining the rest of it. So that's fallen out of favor. It's also an invasive test, so it's fallen out of favor as a diagnostic tool. And you compare that then to our diagnostic tool of the colonoscopy, that, if you have a positive FIT test, you're going to use a colonoscopy to really examine the entire bowel for these polyps or early cancer to remove them. Okay. So in Newfoundland, we do have a colon cancer screening program. The target population is individuals aged 50 to 74 who do not have a personal history of colon cancer. Basically, they're a low risk. They're asymptomatic, and they don't have high risk features for colon cancer. However, oops, didn't mean to go forward then. Colon cancer is so common in the population that not everyone with a family history is considered at increased risk. So you can still qualify for population-based screening with a family history if there's only one first-degree family member, so that would be a sibling, parent, or child who has colon cancer if they were greater than 60 years of age when they were diagnosed, or if it's more distant relatives that have had colon cancer, so second-degree relatives or third-degree relatives. So if this is the limitation of your family history, then you would actually still qualify for population-based testing. And what it looks like in Newfoundland, you get a kit, you put your stool on it, you complete it, you send it back, it gets analyzed and reported, you get a letter. If it's normal, you just automatically rescreen 2 years later. However, if it's positive, then you'd be contacted by a coordinator, a health assessment is completed, colonoscopy arranged, and then depending on the colonoscopy reports, you'd have follow-up either back into the screening program if it's normal, or with further workup with your regional health authority if a polyp was identified or a cancer was identified. So our program has been going on now for just about 10 years. And you can see the number of kits sent out per year has been increasing with a bit of a little peak there over COVID. More kits were sent out. So for 2024, 27,000 FIT testing kits were sent out to the population. 70% were returned. 82% of those were negative. 12% did have positive results, which led to 2,187 colonoscopies in this province last year, with the detection of 58 cancers. So early cancers detected. Another impressive number, though, is the adenoma detection rate, or the polyp detection rate, is 62%. So in 62% of those colonoscopies, a polyp, at least one polyp was identified and removed. And so we're looking at cancer prevention in a number of these cases. And so, finding these cases early is important. This is data from the colon cancer screening program from 2021, where they looked at people who had been diagnosed with colon cancer either through the screening program or not through the screening program. And just over 1/4 of those identified through the screening program had advanced stage disease, so less likely to be cured. However, from those who were identified from symptoms, not through the screening program, more than half had advanced cancer. So we're basically doubling the rate of advanced cancers in the non-screened population. So really showing the importance of screening and catching it early. The one slide that I just on higher risk, people who do have a family history. The guidelines we're currently using for that are from the Canadian Association of Gastroenterologists. So one of these expert society guidelines that differs from our provincial or Canadian guidelines, but really looking at who qualifies for higher risk screening and what that higher risk screening should look like. I won't go through all the details, but again, as we said, people with the lowest risk, so you're just looking at one family history, sorry, one first degree relative or a second degree relative who had a colon cancer or an advanced polyp, really you're looking at average risk guidelines, whereas the more individuals and the closer they're related to you that had cancer, the higher the different your screening should be. For those at highest risk would be 2 first-degree relatives, so a parent, sibling, or child who had colon cancer. And these individuals, we would recommend not a FIT test, not the screening test, but going straight to the diagnostic test of colonoscopy every 5 years. And for some people, if they have frequent polyps found, we'd even say more frequently than that. So that's all I'm going to say about that, just for the sake of time, but just to say there are different screening recommendations out there based on your risk. Okay, moving on quickly to cervical cancer screening. Even though we've been doing HPV vaccination and the PAP test programs have been out there for some time, our rates of cervical cancer are actually increasing in the recent years. You can see since 2015, this curve is starting to go up again. And this is the number of cancers identified per 100,000 women is the number on the left here, and then the year. So you can see it was coming down nicely, and then the last few years it started to go up again. And what this red line is here at 4 is the elimination number. So a number of countries are actually on target through vaccination and through screening to eliminate cervical cancer, to have their rates be less than 4 per 100,000 per year. And Australia, for example, is actually on target to reach that goal by 2035. Cervical cancer is 99% preventable. So this is one that we really should be able to get to. And Canada has actually set a goal of elimination by 2040. The biggest risk factor is the human papillomavirus, and hence the vaccination screen that started a number of years ago now. So this diagram basically shows that quite a large portion of the population is exposed to HPV in their late teens or early 20s. Most people will clear that infection, but some of these infections are persistent and stick around. And some of the strains of the virus are a bit more virulent or more likely to cause damage to the cells of the cervix that with time can lead to precancerous lesions. And a portion of those with time will go on to cancer. So the PAP test would generally identify these precancerous lesions. There are other tests now actually looking for presence of the persistent HPV. So PAP testing and HPV testing are the two main tests that are available for screening. And the goal is, of course, to identify and treat these abnormal cells to prevent cancers. So the cervical screening program in Newfoundland, I apologize, this is a busy slide, but basically anybody with a cervix who is sexually active should be getting cervical screening starting around age 20 and continuing until about age 70, at which point they can consider stopping the screening. In Newfoundland, the screening is annually until 3 in a row are negative. At which point they extend the interval to every 3 years. And I won't get into the details for the sake of time here, but there are certain special circumstances based on the findings and if people had a hysterectomy, etc. Basically, if ascus is these abnormal cells of undetermined significance, and LCIL is kind of a low-grade low-grade changes in the cells, you could repeat the PAP in 6 months. If that's persistent or it's a higher grade change, they go on to colposcopy, which is a different type of test that actually is a bit more invasive, that actually can visualize the abnormal cells and treat them. So that's what the program looks like in Newfoundland. This is a screenshot from the Partnership Against Cancer, the Canadian Partnership Against Cancer, CPAC, that looks at New Brunswick, Nova Scotia, PEI, and Newfoundland, and what their screening programs look like and how they differ. So you can see that the age of eligibility is actually different. And these guidelines have changed over time. They're always evolving. So the age of eligibility has changed and is different for the different provinces. The screening interval is different for different provinces. A number of provinces are considering increasing the age, if they haven't already, to start at 25 instead of 20 or 21. And you can see here, I think I've got it circled, PEI was the first province in Canada to switch from Pap tests to the more modern HPV testing as the primary screening modality almost 2 years ago now. So since then, BC and Ontario have followed PEI, have followed suit, and have implemented HPV screening as the primary test, and others are following suit now. And so again, the Canadian Partnership Against Cancer here has set this goal, as I mentioned, to eliminate cervical cancer in Canada by 2040. And their priorities will be to improve HPV immunization rates, implement HPV rather than Pap testing as the primary screening modality, and to improve follow-up of abnormal screening results. I found some data from 2011, old data, but about a quarter of individuals who have abnormal Pap results weren't getting the appropriate follow-up. So that obviously needs to change. As part of the goal to eliminate cervical cancer, the First Nations, Inuit, and Métis were also, of course, consulted and have another list of priorities, which includes culturally appropriate care closer to home with people-specific self-determined care and a First Nations governed research and data system approach. Moving on to breast cancer. As we saw this diagram earlier, breast cancer makes up about a quarter of the diagnoses of cancer in women in Canada. So this, and it's the second leading cause of cancer death in Canadian women. So the risk factors: increasing age, assigned female at birth, genetics or family history. We talked briefly earlier about hereditary breast and ovarian syndrome, BRCA1 and 2, and now another 18 or 19 genes per panel that we would look at for risk of breast cancer. These really only make up about 10% or so of breast cancer cases. Other risk factors include alcohol use, obesity, dense breast tissue, repeated radiation exposure to the chest, generally with radiation therapy for lymphoma in childhood or before age 30, and previous abnormal breast biopsies, more likely to have future abnormal biopsies as well. So this is one I'm actually going to show the Canadian Task Force on Preventative Healthcare recommendation, because it's actually not as old as some of the others. This was a draft recommendation from just under a year ago that said that breast cancer screening is a personal choice. Women aged 40 to 74 should be given the information, and if they decide to avail of it, should have mammography screening every 2 to 3 years. I just wanted to point out that they define women as cisgendered women, of course, but also transgender men and non-binary or other individuals assigned female at birth who did not have bilateral mastectomy. Just wanted to mention top surgery versus mastectomy is different. Top surgery, generally breast tissue is left behind to make a male breast sort of shape, versus a mastectomy really trying to eliminate, remove all breast tissue. So the risks would be a little bit different depending on the type of surgery that was received. Okay, in Newfoundland, there are 2 different pathways to getting mammography or breast screening. One is through screening centers, through the breast screening program. And the screening centers are in St. John's, Corner Brook, Gander, with 2 satellite clinics in Labrador. With these, there can be self-referral or referral through a primary care provider. There would be a mammogram. The report would come out in a letter format to the patient as well as the primary care provider. And if it's normal, they're automatically rebooked for their next mammography. The other way of getting a mammography is through diagnostic imaging. This requires a physician or primary care provider referral, and the report goes back as a radiology report to them. So in Newfoundland, screening is age 40 to 49 annually, and that's new in the last month. In the last couple of weeks, because previously it was age 50 to 79, and that would be within that age group, screening every 1 or 2 years, depending on the risk factors in terms of including family history and breast density. And based on opening up the or expanding the age eligibility criteria, they've now funded 2 more machines as well, 1 in Central and 1 in Eastern. I'm realizing I'm running out of time, so I'm going to speak even faster. I apologize. Approximately 5% of mammograms result in a recall for further imaging, of which about 5% of those need biopsy, of which approximately 5% of those are cancer. I don't have any data in terms of how this has reduced or found earlier cancers, because again, some data comes in through the screening program and others through the diagnostic imaging, so it's not one data source to look at. For the higher risk populations, we do also have access to annual breast MRI starting age 25 to 70, or annual mammogram starting at age 30. And that would be those who had that radiation for lymphoma or other issues before age 30, or who have a known genetic predisposition, proven or presumptive, which would be a whole other talk in itself if I had time. very quickly, lung cancer screening. So it is the second most common cancer diagnosis, the highest cause of cancer death. And you can see it is in a league of its own here in terms of cancer deaths. But this looks like it's coming down with time, the deaths from lung cancer. And it is, when you look at it, age standardized. So by age category, for every age category, it seems the risk of lung cancer death is coming down based on smoking cessation, better screening, etc. However, when you also look at the fact that we have an aging population, that actually offsets that decrease. So we are seeing overall an increase in lung cancer incidence and mortality because of the aging population. 85% or more of lung cancers are due to tobacco, increasing age, and other chemical exposures are also risk factors. Finding it early stage leads to better outcomes. So identified in a screening program, most are these lower stage 1 or 2 that you can treat with curative intent. Screening outside of a screening program diagnosed by symptoms, much more likely to be a more advanced or palliative situation. I'm going to move on past. So basically, screening with low dose CT scan, age 55 to 74 years, if they're smokers or people are smoking or recently quit smoking. And I will say there have been shown no benefit of chest x-rays of screening for lung cancer. And smoking cessation is a huge part of this. So in Newfoundland, we don't have a program yet. We have a pilot study that can be self-referral or referred through primary care providers. And basically, it's a combination of low-dose CT and assistance to quit smoking. I'm going to go.
Angela,
Yeah.
sorry, if I may just wrap up.
Absolutely. I'm just going through these because of this exact issue. I'm just noticing I'm getting low on time. I've got 4 minutes total left, I think. So I'll go to this and then I'll stop just to say, if I could.
Yes, please, go ahead.
Okay. So in the 18 months that our lung screening pilot has been open, we've identified about just over 1,200 cases have been, or individuals have been referred. A risk assessment is done. I didn't get to go into, but basically, of those 1,200, 832 were considered at high enough risk to go on to a CAT scan. 9 people have been diagnosed with lung cancer who wouldn't have been otherwise, and there are 50 others who have lesions of concern that are getting investigated. 350 people are part of the smoking cessation group, and getting those supports, and 170 incidental findings of breast cancer was diagnosed. Lots of thyroid nodules and other things have come up as incidental findings. So we have found early cancers here as well as other things with this program. We're now waiting to see if this is going to be funded as a new program. I wanted to talk about our smoking cessation program. It's also been quite successful. Oh, this got a bit messed up here, but this is something we have available through our outpatient clinic at the cancer center here. Anybody who comes into our clinic with a cancer diagnosis is asked if they're a smoker or recent smoker. They're offered, or they should be offered, smoking cessation referral, and we have very high rates of attendance and follow through, and about a third of our patients involved quit, or another third are able to reduce their smoking as part of this, which has led to better outcomes. My last summary slide as I clue up, just to say, screening does not equal diagnosis. Some screening tools can prevent cancers, other identified earlier for better outcomes. There are differences for population screening versus higher risk screening. Know what your risks are and what screening is available to you and avail of it. In terms of cancer prevention, some risk factors are within our control, others are not, and do what you can to minimize your risks. So cancer is personal, and so is prevention and screening. And hopefully coming soon. I added this last line while Derek was talking at the end there. I am waiting for announcements regarding whether we're going to be funded for a high-risk cancer clinic in Newfoundland, which will have a high-risk cancer navigator to help navigate these issues with cancer screening and make sure everyone who is at higher risk can avail of it. That is the end. Thank you.
Amazing news. I'm sure Derek is delighted. So am I. So thank you so much, Angela. A lot of great information here. And we have a couple of really great questions. So I'll quickly go through them. Is there any test to determine if you get polyps? This is one of the questions we have.
To determine if you get polyps.
Any test? No.
So not really. If people are known to have a an inherited syndrome, they're more likely to get polyps. But really, the FIT test can identify those small volumes of blood in the stool, which can indicate that there is a polyp.
Right.
Yeah.
Okay. And another two quick questions. So we are looking for a short answer here. What other options are there for breasts with dense breasts other than mammography for screening and diagnostic purposes?
Very good question. So for dense breasts, the more frequent mammography is what's currently recommended. If it's dense breast plus other risks, sometimes we can get to MRI, but it's really a discussion with the breast screening program.
Okay, and one last question. If nobody, like a lot of people don't have family physicians, family doctors, which kind of venues, pathways are available for people without family doctors to, for example, get screened?
So our breast screening clinic program, our cervical screening program, and the colon cancer and the lung cancer, all of the screening programs we've talked about here in Newfoundland at least have a self-referral option as well for those who don't have primary care providers.
Okay. All right, folks. Thank you so much, Angela. Now we are going to go to the next slide, next session. I really would like to thank you for all the great information you provided us in such a short time, but I think we are going to have another conversation about all this beautiful information you have given us today. So thank you again, Angela. Very much appreciated. Now,